And as Dr. Callan mentioned, today I'd like to talk to you about an update in the assessment and treatment of patients with Psoriasis Vulgaris. And here are my disclosures. None of these activities impacted the formulation or content of this presentation. And our learning objectives for this morning are to review the general features of Psoriasis Vulgaris, to discuss the systemic inflammatory nature of psoriasis, as well as some select comorbid diseases, to describe key aspects of the clinical assessment of patients with psoriasis, and then finally we'll end with an update in our treatment options for patients who have moderate to severe psoriasis. So let's begin by just reviewing some general features about psoriasis. And I'm sure, as most of you in the audience know, psoriasis is a very common, chronic, immune-mediated skin disease. It affects upwards of 2 to 3% of the entire world's population, and it represents one of the hallmark Th1, Th17 inflammatory diseases, being characterized by what are now very well-known pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin-17, and interleukin-23. And although psoriasis rarely in and of itself is life-threatening, it has a tremendously negative impact on patients' quality of life, being associated with low self-esteem, stigmatization of patients that affect their social and their professional lives, and clinical depression in a high percentage of patients. And in addition, it has a tremendous impact economically on our healthcare system, with costs related to psoriasis totaling over $11 billion per year in the United States itself. And what you may not know is that psoriasis is a heterogeneous disease. There are a number of different clinical subtypes of psoriasis, and each of those subtypes can be associated with skin lesions that have specific morphologies and that may affect different anatomic locations. And it's important to be aware of the different subtypes in order to make an accurate diagnosis. Plaque psoriasis is far and away the most common subtype of psoriasis. And it's probably what most of us visualize in our minds when we think about psoriasis. This accounts for about 80 to 90% of all psoriasis cases, and it presents with these very well-demarcated erythematous plaques that have this thick, overlying silvery white scale. Guttate psoriasis is another relatively common subtype. This usually presents with a fairly acute onset of small erythematous papules, some of which have that overlying silvery white scale on the trunk and extremities. And this can occur in adults, but classically it occurs in children or adolescents following a streptococcal infection like streptococcal pharyngitis. Inverse psoriasis, in some ways, is the opposite of plaque psoriasis. Plaque psoriasis has a predilection for extensor surfaces like the elbows and the knees. Inverse psoriasis affects flexural surfaces, the axillary vaults, the inframammary areas, the groin. And it tends to lack that thick overlying scale because the areas affected are moist and don't allow it to build up. And erythrodermic psoriasis implies that at least 90% of a patient's body surface area is involved with psoriasis. And again, this subtype tends to lack that thick overlying scale. So I think that there are many other subtypes, but this gives you a sense of the heterogeneous nature of this disease and how many different other skin disorders may mimic it. Despite that, most dermatologists can make a diagnosis of psoriasis clinically by simply taking a clinical history and by doing a thorough physical exam, paying particular attention to the morphology of the skin lesions and the anatomic locations that are affected. But with that said, there are certainly times where we need ancillary test results to feel confident we're making a diagnosis and distinguishing between other disorders. And in dermatology, one of those key tests that we will do is a skin biopsy. So on this slide, we have two photomicrographs, one of normal skin and one of psoriatic skin. And in the normal skin, what we see is in this uppermost layer, the stratum corneum, there's this very loose basket weave pattern. The epidermis underneath is relatively thin, but that's normal thickness. And then in the dermis, there's really just a scant number of inflammatory cells, probably there to perform immune surveillance activities. And in psoriatic skin, we see changes at all levels of the skin. The stratum corneum loses that basket weave pattern, is significantly thickened and compact. And this is actually that thick silvery white scale that we visually see on the patient. The epidermis is significantly thickened, mainly because the keratinocytes are proliferating at a significantly high rate. And then in the dermis, we see a relatively dense inflammatory infiltrate. And we've learned over the years that it is this inflammatory infiltrate that is really driving all those other changes in the skin. And over the past several decades, we have come to realize that that inflammation is not confined to the skin, but can be throughout a patient's body. That psoriasis is a systemic inflammatory disease. It's not just a skin disease. And if that systemic inflammation is not treated adequately, patients can develop a number of important comorbid diseases over time. And this is not a comprehensive list, but certainly some of the diseases that are listed on here we probably may think of as more significant than psoriasis itself. But studies have shown that patients with psoriasis are at increased risk for developing all of these diseases compared to patients in the general population. And if the psoriasis is severe, patients are at even increased risk compared to mild psoriasis for developing some of these. And we're going to spend some time talking about two of the diseases on this list: cardiovascular disease and psoriatic arthritis. Clues that psoriasis may be associated with an increased risk of cardiovascular disease date back to the 1970s, when Drs. McDonald and Calabrese showed that the risk of arterial and venous vascular diseases was more than twice as high in psoriasis patients compared to patients who had other chronic dermatologic conditions. And some of those vascular diseases included myocardial infarctions, pulmonary emboli, and strokes. And to some degree, they found that the extent of skin involvement also predicted how high the risk was. And throughout the years following these manuscripts, there were a few studies that continued to look at this association. But really, the attention of researchers concerning this relationship came after a paper was published in JAMA in 2006 by Joel Gelfand, who is a dermatologist at the University of Pennsylvania, and his research colleagues. Dr. Gelfand and his colleagues looked at the risk of myocardial infarction in patients with psoriasis by examining a population-based cohort. They looked at over 130,000 patients with psoriasis and over 500,000 control patients from a UK database. And they found that patients with psoriasis had a higher incidence of myocardial infarction compared to the control patients. And as you can see here, the relative risk increased with increasing severity of psoriasis. But they also showed that this increased incidence of myocardial infarction was independent of other cardiovascular risk factors like hypertension and diabetes. So in other words, psoriasis in and of itself was an independent risk factor for having a myocardial infarction. And this paper really sparked an explosion of research surrounding the relationship between psoriasis and cardiovascular disease. And over the next few years, research studies showed an association between a number of cardiovascular pathologies in psoriasis, like valvular pathologies, arrhythmias, stroke, peripheral artery disease, coronary artery disease, with some of the more striking results of studies being, for example, that patients with severe psoriasis may have as high as a 60% increased risk of cardiovascular death compared to control patients without psoriasis, but who still have other cardiovascular risk factors. Patients with not only severe psoriasis, but also mild psoriasis have an increased risk of stroke, with patients who have severe psoriasis having as high as a 44% increased risk of stroke, and patients with moderate to severe psoriasis having a reduced life expectancy of about 5 years, mainly due to that increased risk of cardiovascular disease. And there are probably a number of reasons for the association between psoriasis and cardiovascular disease, but certainly one of those reasons is because we know atherosclerosis in and of itself is an inflammatory disease, and the pathophysiology of atherosclerosis involves Th1-mediated immune responses. In fact, they are necessary for the initiation, but also the progression of atherosclerotic plaque inflammation and stability. But the pathogenesis of atherosclerosis also involves Th17-mediated inflammatory responses and pathways, as well as a number of inflammatory cytokines and a decrease in T regulatory cells. But what's really interesting is if we look at the pathophysiology of atherosclerosis and the pathophysiology of psoriasis side by side, they are eerily similar in that many of the key pro-inflammatory cytokines and inflammatory pathways are identical. And these similarities really are what provide that direct pathophysiologic link between psoriasis and cardiovascular disease. And in recent years, we have actually begun to visualize this inflammation in psoriatic patients. Nehal Mehta is a preventative cardiologist at the NIH. He also works at the University of Pennsylvania, and he has done some of the best work surrounding the relationship with psoriasis and cardiovascular disease. And this is one of his papers. This was published in 2011. And what he did here was take 6 patients who had severe psoriasis, which he defined as greater than 10% body surface area, and 4 control patients who were matched by both age and sex to 4 of those severe psoriasis patients. And he performed FDG PET-CT imaging. And what he showed was that compared to the control patients, FDG PET-CT can identify increased uptake or increase in inflammation in a number of organs in psoriasis patients. From a vascular standpoint, throughout the aortic wall, throughout the femoral arterial tree and other blood vessels. It was also diffusely throughout the liver and in numerous areas of joints, the trochanteric bursa, the knee joint, the ankle. And granted, these are patients who had absolutely no musculoskeletal symptoms. So this is really proof of the concept that psoriasis is in fact a systemic inflammatory disease, and to treat it appropriately, especially in patients who have moderate to severe disease, we need to address it as a systemic inflammatory disease. Now, despite this knowledge, we as caregivers currently do not do a very good job of protecting our patients as well as we could from future cardiovascular events. This was a paper in 2012, also Nehal Mehta involved in that, where they looked at almost 3,000 patients with moderate to severe psoriasis and modifiable cardiovascular risk factors. And they showed that luckily the minority of patients had undiagnosed modifiable cardiovascular risk factors. However, a significant percentage of patients, despite those diagnoses, were not being treated for the modifiable cardiovascular risk factors. Additionally, a high percentage of patients, even though they were treated, were not being treated at goal. So we still have a lot of work to do in order to optimize protecting our psoriasis patients from future cardiovascular disease and cardiovascular events. And of course, that takes all of us, not just dermatologists, but clearly primary care physicians, cardiologists, and really any of us who see these patients with moderate to severe disease. Psoriatic arthritis is another very important comorbid disease that occurs in patients with psoriasis. It is the most common comorbid disease that occurs in these patients. It is a chronic seronegative inflammatory arthritis. It affects upwards of about 20 to 35% of all psoriasis patients. And importantly, in the majority of patients, skin psoriasis will occur before the onset of psoriatic arthritis. In some studies, as high as in 85% of all patients. And additionally, studies have shown that the lag time between onset of skin psoriasis and onset of psoriatic arthritis can be between 4 and even 12 years. So what that means is, by the time these patients begin to develop psoriatic arthritis, they are most likely going to be under the care of just dermatologists and primary care physicians. So we are really in a unique position to be able to diagnose these patients at onset and make sure they have an appropriate diagnosis and begin appropriate treatment. And that's important for a number of reasons. Additionally, it's important that we recognize that any patient with psoriasis can develop significant joint disease. There's no real correlation between the severity and course of the psoriasis and the severity, of course, of psoriatic arthritis. There does seem to be a higher incidence of psoriatic arthritis with more severe psoriasis, but patients with mild psoriasis can develop severe disabling joint disease. So we have to really ask all of our patients about it. With that said, a diagnosis of psoriatic arthritis can be extremely challenging in some cases. For one, there's no universally accepted diagnostic criteria. Like cutaneous psoriasis, there are heterogeneous presentations. They can have a peripheral arthropathy. They can have a spondyloarthropathy, combinations, different patterns. And it's a seronegative inflammatory arthropathy. There's currently no serum diagnostic test that we can use to help us make that diagnosis. So the diagnosis is primarily a clinical diagnosis. And this is underscored by a study called the PREPARE study. In the PREPARE study, which was published in 2013, about 950 psoriasis patients were screened by rheumatologists for the presence of psoriatic arthritis. And they found that 285, or about 30%, as expected, had psoriatic arthritis. But what they found was that if additional serologic tests were done, that only changed their clinical diagnosis about 1% of the time. And if additional radiologic studies were done, it only changed their diagnosis in about 4% of the patients. So this is primarily a clinical diagnosis. And although there are no universally accepted criteria, the most up-to-date accepted criteria are the CASPAR criteria, the classification criteria for psoriatic arthritis. And it's at least worth being knowledgeable about these criteria. These are the criteria that are used to include or exclude patients in really all of the current psoriatic arthritis clinical trials that are ongoing or that have been done. And in the CASPAR criteria, you first have to establish that a patient has an inflammatory arthritis. And if you're confident about that, then you assess for the presence of a number of clinical factors. First, does the patient have psoriasis? If they visually have psoriasis on their body, at that point they're given 2 points. But even if they have a history or even a family history of psoriasis, they're given 1 point. If they have nail changes indicative of psoriatic disease, they're given 1 point. If they have a negative rheumatoid factor, they're given 1 point. If they have dactylitis or diffuse swelling of an entire digit or even a history of dactylitis, they're given a point. And then there's only one criteria that is radiologic in nature, and that's presence of juxtaarticular new bone formation, which is this ill-defined ossification near the joint margins. They're given a point for that. And if a patient has a total of at least 3 points, then they are said to meet criteria for psoriatic arthritis diagnosis. So a lot of this, if you think a patient has inflammatory arthritis, if they have evidence of psoriasis, that's very strong evidence that you're probably looking at psoriatic arthritis. And this is the juxtaarticular fluffy periostitis, just this ill-defined ossification that occurs at the joint margins. So what's the importance of this diagnosis? There's a key difference between cutaneous psoriasis and psoriatic arthritis when it comes to the time of diagnosis and initiating appropriate treatment. We can see patients who have the most severe psoriasis, and they can walk around in that state for 20 plus years. And if we put them on a medicine that works well, their skin will clear, and it will look as if nothing ever affected it. There's no permanent damage to the skin. That's not the case with the joints. With the joints, you can get destructive changes that are permanent and will, from that point forward, negatively affect a patient's quality of life and their potentially ability to work, ability to do activities of daily living. And studies have shown that those permanent changes can occur very early in disease. In up to 25% of patients, there are joint erosions as well as some degree of joint space narrowing at the time of diagnosis, and that percentage can increase to almost 50% after 2 years of onset if this isn't treated properly. And so by treating patients, making that diagnosis early and treating patients appropriately as early in the process as possible, we can help prevent some of these severe destructive changes, which in the most severe cases in arthritis mutilans creates changes on radiographs like this, where clearly this patient cannot use his or her hand as well as he would like. And you can get these severe changes, which has been described as pencil and cup deformities, which extensive erosions and joint space narrowing. Okay, so now that we've talked a little bit about the general features of psoriasis and some of the important comorbid diseases, let's talk about some of the key aspects of what we do when we assess these patients in our clinic. One of the most important things we do as soon as we see these patients is get a sense of the severity of their disease. And the National Psoriasis Foundation has published definitions of disease severity based on body surface area involvement of psoriasis, with mild disease being defined as anything less than 3%, moderate 3 to 10%, and severe disease anything greater than 10% body surface area. And you can think of 1% of your body surface area as the surface area of your palm. So if you have less than 3 palms worth of psoriasis, you have mild disease. If you have greater than 10, which really, I think when you think about it, is not that much, it's considered severe disease. And I think we've already seen that 10 palms worth of psoriasis is associated with a significant amount of systemic inflammation. So it really doesn't take that much body surface area involvement before you're really seeing a patient who has significant increased risk of a number of comorbid diseases. With that in mind, it's also important to recognize that simply calculating body surface area alone is not enough to assess the full severity of the disease in any given individual patient. We also have to take into account other aspects of the disease. For example, physical symptoms. A lot of patients with psoriasis have physical symptoms. Over 80% experience some degree of skin pain, and over 90% experience pruritus. And that pruritus can be severe enough in a significant percentage of patients to even affect their ability to sleep properly. So you can imagine that a patient can have mild disease, less than 3% body surface area, but if it's on the palms and soles, that may affect the patient's ability to participate in recreational activities, their ability to work, and again, even their ability to perform activities of daily living. And certainly I think we would all consider that to be severe disease despite having a low body surface area involvement. Additionally, as we mentioned initially, psoriasis has a tremendously negative impact on patients' psychologic health. And again, a patient can have mild body surface area involvement, but if that disease is affecting the face, the genital areas, it has a tremendous impact on the patient's lives. with studies showing that upwards of 90% of patients experience embarrassment, helplessness because of their psoriasis, and up to 60% really meet diagnostic criteria for clinical depression. So again, I think we'd all consider that sort of impact as being severe disease despite the amount of body surface area involved. Additionally, as hopefully you all can understand by now, it's critically important to assess patients for the presence of psoriatic arthritis. Because despite the amount of body surface area, if psoriatic arthritis is present, that is going to immediately impact the treatments we have in mind for the patient. So we have to all know a little bit about the different patterns of psoriatic arthritis and different manifestations of disease. For example, dactylitis, which is diffuse swelling of a digit, a finger or toe, which really implies that there's synovitis and enthesitis at different interphalangeal joints within that same digit. Dactylitis occurs almost twice as often in a toe as in a finger. So it's important for us to make patients take off their socks. That simple task can really provide tremendous insight into what is going on with the patient. Enthesitis is inflammation at the point where a tendon or a ligament inserts in bone. And there are a number of areas where this can commonly occur, but the Achilles tendon is one of those areas. You can see how swollen this is. Now, unfortunately, in clinic, I've never had the luxury of having it this easy, but just to understand the manifestations of psoriatic arthritis can be helpful in assessing these patients. And simply asking them questions. Do you have stiffness in the morning or after long periods of inactivity? Do you have pain or swelling in any of your joints? Do you have pain or stiffness in your back? All of those can help make you suspicious about a diagnosis of psoriatic arthritis. And in fact, the American Academy of Dermatology recommends that we dermatologists screen patients for the presence or onset of psoriatic arthritis at every single clinic visit, regardless of the severity of their disease. Now, there are also a number of validated psoriatic arthritis screening questionnaires that are available to download on the internet, and these can be provided to psoriasis patients when they're in the lobby or when they're in their exam room before the physician comes in. This is one of them. It's called the PACE questionnaire, and here the patient answers 15 questions and circles their answer, and then all these points are added up, and depending on the total number of points, it's recommended to either consider a referral or that you should do a referral to rheumatology if you're uncomfortable making that diagnosis yourself. As you can imagine, the American Academy of Dermatology has also published guidelines concerning screening patients for modifiable cardiovascular risk factors, as well as other comorbid diseases. This is getting to be a little bit dated, so there may be updates soon, but those guidelines are out there, also encouraging moderation of alcohol intake and some degree of exercise. And as well as concerning the management of these modifiable cardiovascular risk factors, at this time it's recommended that we really adhere to the standard prevention and treatment targets that have been published by other organizations. Now again, these were the current up-to-date guidelines at the time of this publication, but it makes sense that as these are updated, and some of them have been, to follow the new updated guidelines. Now what we don't know is whether or not patients with severe psoriasis should really have more aggressive target goals when we're thinking about how to treat their modifiable cardiovascular risk factors. The ATP3 certainly recognized that emerging risk factors may play a role in defining new targets. In this study, which again involved both Nehal Mehta and Joel Gelfand, who worked together a lot, they performed a cohort study. And after adjusting for a number of factors, they found that severe psoriasis in and of itself conferred a 6.2 absolute risk of a 10-year major adverse cardiovascular event in those patients. So more work needs to be done, but in the future, we may find that for our patients who have severe psoriasis, which in general for these types of guidelines really means at least 10% body surface area, that we may need to treat their modifiable cardiovascular risk factors much more aggressively than the general patient in the population or even patients with mild psoriasis. Okay, so now that we've assessed patients for psoriasis, how do we treat them? So I'd like to close with just an update in treatment options specifically for patients with moderate to severe psoriasis. Over the past several years, the Medical Board of the National Psoriasis Foundation has published treat-to-target guidelines for psoriasis patients. And this is very welcome because dermatology really has fallen behind other disciplines like gastroenterology and rheumatology concerning these types of guidelines. And the medical board defined body surface area involvement as really the best instrument to use at this time, mainly because it's very quick and easy to estimate a body surface area, especially in a private, very busy clinical practice. And through a Delphi process and further discussions, it was recommended that the preferred target response would be that a patient have no more than 1% body surface area of psoriasis after 3 months of initiating treatment and from that point forward during maintenance therapy. Although they acknowledge that an acceptable response would be anything less than 3% body surface area or at least a 75% improvement in body surface area involvement. And these may change over time, but these are our treat-to-target goals. So that's pretty aggressive when you think about it. Less than 1 palm's worth of psoriasis on the patient is what the goal is, the recommended goal. Now, we're lucky in that we can probably meet that goal in most patients. And a lot of that is because over the past 30 years, we have learned a tremendous amount about the pathophysiology of psoriasis, such that at this point in time, we know that in patients who are genetically predisposed to the disease, they need some external trigger, a viral infection, some other life stressor, to initiate activation of cells in the innate immune system, including keratinocytes and plasmacytoid dendritic cells that release pro-inflammatory cytokines and activate myeloid dendritic cells. Activated myeloid dendritic cells then engage cells of the adaptive immune system, Th1 cells via interleukin-12, Th17 cells via interleukin-23, and these cells release additional pro-inflammatory cytokines that activate keratinocytes to release chemokines, inflammatory cytokines, antimicrobial peptides that act then back on cells of the innate immune system and create this chronic vicious loop of inflammation that, as of today, we have no way to completely turn off once it's initiated. But because of this detail of understanding, we have been able to develop a number of medications that have been very welcome in our practice and have revolutionized our ability to control moderate to severe psoriasis. Now, we still use our traditional medications on a daily basis. However, really what has revolutionized our ability to control these patients are the biologic medications and small molecule inhibitors. And for those of us who treat psoriasis, quite frankly, we are spoiled with the choices we have. There are other medicines here, but in really today's landscape in the medicines that we prescribe on any regular basis, there are a number of families of medicines up here. And since 2004, there have been 11 medications that we have to choose from on a daily basis to treat our patients with moderate to severe psoriasis. And another agent that is probably very close to FDA approval, probably within the next few months. So the TNF inhibitors, this is really the family of medications that we use on a regular basis that has been around the longest. There are 4 of them: etanercept, infliximab, adalimumab, and certolizumab. Certolizumab was just approved this year, but the other 3 medications have been available to us for more than 10 years now. And etanercept in 2016 was approved by the FDA to use in moderate to severe plaque psoriasis in children ages 4 to 17. So that has been a huge win for children who are unlucky enough to have moderate to severe psoriasis. The IL-12/23 inhibitors, there's one of these medications, ustekinumab. It's been available for 10 years, and in 2017 the FDA approved it for use in patients with moderate to severe psoriasis between the ages of 12 to 17. Again, a big win for those young adults who are unlucky enough to have this disease. Apremilast is a small molecule inhibitor. It is an oral medication that was FDA approved in 2014, and it works within cells to block phosphodiesterase 4, and in blocking that prevents the production of pro-inflammatory cytokines. And if we look at the phase 3 trials, we can see these medicines work really well. In our phase 3 trials, really the primary outcome measure is PASI 75. Now, without getting into the details, PASI is simply a clinical scoring tool for the severity of the disease. It takes into account body surface area involvement and the degree of erythema, the thickness of plaques, and the degree of scale. And PASI 75 implies there's at least a 75 improvement in that PASI score from baseline to whatever time point you're measuring, usually between 10 and 16 weeks in these trials. PASI 90 implies at least a 90% improvement. PASI 100 implies 100% improvement. Complete clearance of the skin. No trace of psoriasis left on the body. And you can see the majority of patients, especially with the biologics, achieve PASI 75, and a significant percentage, even 90% improvement, and a small percentage of patients even completely clear. Apremilast doesn't really have the degree of efficacy as these biologics, but it does have its place in our algorithm of treatments. Also, we have begun to learn about the safety of biologics, mainly because now the TNF inhibitors have been out for over 10 years. So importantly, we've been able to accumulate a lot of real-world data, and that's mainly because there have been a lot of national or even international registries that incorporate patient data for these individuals on these medications. One of the big ones is a registry called the SOLAR registry. And in this publication, even by 2015, they had over 11,000 patients enrolled and had accumulated over 22,000 patient years of biologic exposure. And what they learned is that really the risk of serious infection is quite low, somewhere between about 1.5 and 2.5 per 100 patient years, with maybe some of the TNF inhibitors having a slightly higher risk than the other medications. We've also learned that the risk of malignancy on patients exposed to biologics is really quite low, and this was probably one of the biggest fears we had when these medications began coming to market and we began using them in patients. In this study published this year, there was over 27,000 patients included, almost 60,000 patient years of biologic exposure. And importantly, they grouped all the biologics together because patients in the real world are typically exposed to different biologics over time. They may lose efficacy and we switch them to something else. And what they found was that the cumulative length of exposure to biologics was not associated with the risk of developing cancers. And the results persisted after controlling for a number of different risk factors. What about cardiovascular events? I think this is really the holy grail. Will these medicines help prevent cardiovascular events and cardiovascular disease in these patients? This was a study from 2017 where Jiaxin Wu and his colleagues looked at a U.S. administrative claims database. So they had over 9,000 patients on TNF inhibitors, and they compared them to about 8,500 patients who were taking methotrexate, and looked at major cardiovascular events, which were defined as hospitalization for an MI, stroke, TIA, or unstable angina. And what they found was that patients on TNF inhibitors had fewer major cardiovascular events than patients on methotrexate, really at any point studied in time. And the 12-month rates were only 1.45% for TNF inhibitors versus 4%. And there was a difference based on cumulative exposure as well. With over 24 months, each additional 6 months of TNF inhibitor exposure was associated with an additional 11% risk reduction in major cardiovascular events. This is a study by Nehal Mehta and his colleagues. So here, what they did was they looked at 115 patients with mild to moderate psoriasis, and they did FDG PET-CT scans at baseline, and 1 year after patients were on a variety of medicines, from topical medicines to phototherapy to TNF inhibitor therapy. And they showed that any improvement in skin disease was associated with some improvement in vascular inflammation. But the association also, it persisted beyond modifiable cardiovascular risk factors and was strongest in those patients with TNF inhibitor therapy. So here's a patient at baseline, and you can see this increased signal throughout the aorta, all segments, and then 1 year after being treated with a TNF inhibitor, significantly decreased. With that in mind, not all studies have shown positive results. And this is a study that's currently in press by Joel Gelfand and his colleagues called the Vascular Inflammation and Psoriasis Trial, or VIP trial. And importantly, this was a randomized controlled trial where patients were exposed to TNF inhibitors or not exposed, and it was well-powered. And this trial demonstrated no benefit of TNF inhibitor therapy on aortic vascular inflammation. It did, however, show that there was improvement in the risk factors such as CRP levels and glyc-A, and perhaps this provides some evidence that TNF inhibitor therapy does have future benefit on cardiovascular events. But as Dr. Gelfand was quoted in a recent editorial, despite all of these advances that we're talking about today in psoriasis research, we're still, unfortunately, at the very beginning of really understanding how treatment with these new biologic medications will impact risk of cardiovascular events in the future. More recently, we have had two other classes of medications available to us. The IL-17 inhibitors are one of them. There are 3 of these medications, all approved between 2015 and 2017. And if we look at the clinical trials, the IL-17 inhibitors seem to begin separating themselves from our previous medications in terms of the percentage of patients who achieve at least 90% improvement in their PASI scores and the percentage of patients who clear. In these clinical trials, really somewhere between a quarter and close to 50% of patients completely become clear of their psoriasis. And our newest class of medications are the IL-23 inhibitors. There are 3 of these. 2 of them, guselkumab and tildrakizumab, are approved. Risankizumab, phase 3 trial data has been published. We're expecting this to be approved sometime in 2019. And there's a lot of excitement around these medications, and they have been referred to by some experts as immune disruptors, and that's because IL-23 is really viewed as sort of the master pro-inflammatory cytokine in psoriasis. One reason for that is because it is required for the terminal differentiation as well as survival of Th17 cells, which are thought to be the key pathogenic cells in psoriasis. So by blocking IL-23, we may be promoting apoptosis of these cells, so really decreasing the amount of pathogenic Th17 cells in patients. And additionally, interleukin-23, because it's so upstream in the inflammatory process, by blocking it, we can block production of other downstream cytokines that we think are important, including interleukin-17A, which are what all those IL-17 inhibitors block by and large. If we look at the phase 3 data here, there's good PASI 90 and PASI 100 improvement. The low end of the scale is really tildrakizumab. So if we look at just guselkumab and risankizumab, again, the improvement, the efficacy of these medications is really quite remarkable, with upwards of 85% of patients achieving at least 90% improvement in PASI score, and in some studies, 51% of patients completely clearing. 1 in every 2 patients with moderate to severe psoriasis exposed to the medicine completely clears. That's pretty amazing. This is the phase 3 data for risankizumab, and you can see here by week 16, at least 75% of patients have at least 90% improvement, and at 1 year, 82% have at least 90% improvement. Here, 16 weeks, 51% of patients completely clear of all psoriasis, and that's as high as 60% of patients out to 1 year. Now, risankizumab is not yet approved by the FDA, but guselkumab is approved, and we now have 3-year data for that medication. So at week 48, between 76 and 82% of patients had reached at least PASI 90. And if we follow this out 3 years, that stays stable. And if we look, a lot of times in these studies when they're followed out years, a lot of patients drop off, and that makes the percentages look good. Very few patients have dropped off over those 3 years. So once this medicine starts working, it seems to continue working. And it's similar for the PASI 100. So patients who are completely clear at week 48 typically will also be clear 2 years later at week 3, or at year 3. And again, very few of these patients fall off over time. So again, we are quite spoiled with the options we have to treat psoriasis. Now, because these medicines are new, again, it will require time before we begin to really understand how safe they are. As of now, there are no concerning safety signals, and the impact on comorbid diseases, specifically how well these protect patients from future cardiovascular events. So in summary, psoriasis is a very common, heterogeneous, systemic inflammatory disease. It is associated with increased risk for numerous important comorbid diseases, especially psoriatic arthritis and cardiovascular disease. Appropriate assessment of psoriatic patients includes not only assessing disease severity, but also identifying and ensuring these patients are treated for any associated comorbid disease or risk factors for those diseases. And we are lucky in dermatology as the treatment for moderate to severe psoriasis has been revolutionized by the introduction of numerous biologic medications. So with that, I thank you for your attention. I'd be happy to answer any questions that you may have.
I would be curious, cardiovascular events, is the chronic inflammation affecting the ultrastructure of the arterial wall? Because you're showing with psoriasis in the skin, there's an extension of the dermis and more inflammatory cells. Is that happening in the vasculature too? Is that where that cardiovascular comorbidity is coming?
No, I don't think that the changes are that striking. It's not analogous to what we see in the skin, but yes, I think we do believe that, especially because the pathogenesis, the inflammatory pathways and cytokines are so similar, that the systemic inflammation and inflammation in the vascular walls is promoting the development of atherosclerotic plaques. The details of the histopathology in the vascular walls, I'm not sure about.
Yes. Have you seen patients on the IL-17s develop inflammatory bowel disease? I've had 2 out of 4 patients on ixekizumab develop inflammatory bowel disease within 6 months on therapy. And then how do you separate that from the inherent risk of that potentially even occurring to psoriasis itself? A little bit more gun-shy now from my anecdotal experience, the risk, but that class makes me a little more nervous than the IL-23s because you don't have as much of that risk.
I have had one patient with a history of IBD, and in co-managing that, this patient has a number of other issues, psoriatic arthritis and inflammatory bowel disease. And because of everything going on, we decided as a group to start an IL-17 inhibitor because he was well controlled from an IBD standpoint and did flare. And it was hard to get it back under control. So I think, a lot of these medicines, as you know, Courtney, are associated with their own specific risk factors. And I think for patients with either a strong history, family history of IBD, or a known history, I avoid them. And I think we're lucky enough that we have all these other choices that we can usually get their disease under control. So yeah, I have seen that, and I do try to avoid it in those patients if at all possible.
Yes.
First of all, wonderful talk. Kind of a quick commentary, I guess, on the effectiveness of direct-to-consumer advertising. You know, we live in this day and age of psoriasis, wonderful responses, but I find the one that I get the most questions from directly from patients is for criminalized. How do you use that? I mean, notwithstanding, immune background issues, so folks who can't get biologics, how do you kind of use that within your day-to-day practice? Because again, that's the one that I tell patients, hey, I don't think this is a great medication. That concerns about immune dysregulation and that option. If you have a particular subtype of psoriasis that you like to use that one in for one reason or another.
So there are some patients where we try really hard to get that medicine. So, for example, we have a patient with pretty significant psoriasis and arthritis mutilans, so really disabling joint disease, who has developed numerous infections on biologics and, in fact, has latent TB that is resistant to anything that can be thrown at it. And so that's a patient who we have on apremilast and luckily is doing well. I agree with you. I think in general the efficacy is not anywhere near what we see with the biologic medications. In general, the way I truly, sincerely feel spoiled to treat psoriasis. When I see a patient with psoriasis, I usually try to briefly tell them about the options, including apremilast. And I really like the patient to play a role in the decision making because I think it helps build a relationship, but also I feel more confident that the patient is going to actually take that medicine if they feel like they're playing some role. And if a patient wants to try apremilast first, I have no problem trying to get the medicine for them. A lot of times I can't. But I feel as if, it's going to play itself out. I'd like to see patients back about 3 months later. And if it's not working, usually the patient is ready to come off of it. So that's what I do. I don't have a problem if a patient comes to me wanting to be on a specific medicine because I feel they're good options. If it works, great. And if it doesn't, then we'll move on.
John?
Great talk. I'm very interested in the risk factors of cardiovascular disease. I see a lot of patients with lupus, for example, and medical involvement as well that increase cardiovascular risk. A lot of the risk assessments, wouldn't put these patients at high risk, so we kind of guide you not to put them on statin therapy. I think that we're under-treating modifiable risk factors for these patients with inflammatory conditions.
Our data, at least in psoriasis, suggests that we are definitely under-treating them. And again, I kind of alluded to the idea that at least some of the experts, Nehal Mehta, I think, if you ever have a chance to hear him talk, he's an outstanding speaker, but he also does great research. And, he's a preventative cardiologist. So he's really spearheaded a lot of this work and believes strongly that we are under-treating these patients, and also believes that we probably should be treating patients with severe psoriasis to more aggressive targets for, their lipid panels and their hypertension. So if that answers your question, I think yes.
The same goes for rheumatoid arthritis, lupus, a lot of these inflammatory conditions. We know a lot of them affect younger people who the cardiovascular risk assessment scores don't really put them in high risk, but these diseases do.
Right, because of the systemic inflammation. And also, I think really, truly the holy grail for psoriasis with all these medications is how well do the medications themselves really protect patients? And if they do, would that really change how aggressively you treat some of these modifiable risk factors? Because in a sense, that's doing some of the work for you. But we just do not seem to have the answer to that question yet.